This study is based on the concept that there is dysregulated deposition of C1q on synapses in a dysfunctional and dysregulated way in various neurodegenerative diseases, including Huntington's disease. This activates complement, causes the migration of various immune cells into the CNS, and also causes microglia to be activated, which results in the engulfment of dysfunctional of these synapses and eventually neuronal cell death, and then, of course, brain atrophy and symptoms in patients with Huntington's disease. So the concept is by knocking down C1q with a monoclonal antibody that we can, at the very top of the cascade, prevent this gradual development of neuroinflammation and, of course, synapse and cell loss. So in this study, we enrolled 28 patients with early manifest or late pre-manifest Huntington's disease with a CAP score greater than 400, and they received this anti-C1q antibody ANX005 over a period of 24 weeks. So they first underwent induction dosing with a 21-hour prolonged infusion. All of the patients had a pseudoallergy or skin rash that was managed with use of antihistamines and IV steroids. In almost all cases, the rash completely resolved by the end of the 21-hour infusion. Then patients underwent additional dose at day 5 or 6, and then every 2-week dosing until the end of the dosing period. Then they were followed in the off-drug state for 12 weeks. So the complete study went on for 36 weeks. What we found is that overall there was stability of the composite UHDRS in the group as a whole, as well as the total functional capacity score, and the neurofilament light levels remained stable. What we found is that if we divided the groups between those people with a high level of complement activity in the brain, as measured by the ratio of activated complement, C4A, to inactive complement, C4, we were able to separate the two groups into those who presumably had high intrinsic complement activation or neuroinflammation as an important part of the pathogenesis of the progression of their Huntington's disease. And in these high complement active groups, or the high ratio groups, we were able to show that there was a fairly quick improvement in the composite UHDRS, as well as improvement in certain subcomponents of the CUHDRS, which drove this improvement, such as the total motor score, which was also statistically significantly improved by the end of the dosing period. As well, we had a trend towards improvement in the symbol digit modality test, and stability and a trend towards improvement in the total functional capacity without improvement in the Stroop reading test, or the SWR. So we saw indeed that there was an improvement in the subgroup of individuals. Now, we also found that there was a reduction in certain biomarkers of neuroinflammation, such as the YKL40 in those individuals, again, who had the high baseline level of complement activation is measured by C4A to C4 ratio compared to those with the low ratio. So it seemed like very promising, and that it intrinsically made sense. And although it was an open label study, of course, we're separating the groups based on this biomarker of complement activation. So we think that it's unlikely to represent any sort of placebo effect. And of course, the patients, the investigators, and the sponsor were all blinded to this amount of complement activation at baseline. Now, there were some adverse effects. As I mentioned, there's a pseudoallergy that developed in all patients. We had one patient dropped out because they developed COVID, one patient who withdrew consent, and then there were 3 other patients who were discontinuing the study. And this is important to understand that these 3 patients all had an elevated baseline ANA level of at least 1 to 80. And one patient developed pneumonitis, another patient developed a lupus-like skin rash without end organ involvement, and one patient had asymptomatic hemolytic anemia. And as a result of these autoimmune reactions, we withdrew these patients from the study, stopped the investigational product, and over the next several weeks to a couple of months, these adverse effects resolved as the knockdown of complement was resolved. So we were able to show on the PK studies that we immediately made C1q undetectable after the initial infusion, both in the serum and CSF, and gradually in the off-treatment observation period, as we measured serum and CSF complement, this increased, and of course, the level of the antibody decreased in serum and CSF. So that's the overall study. We think that the study is very promising in that this represents a unique therapy based on a different mechanism of action than Huntington knockdown therapies. It could be potentially combined with other therapies like Huntington knockdown therapies. We did not see a decline or an increase in in NFL level. This was a short study, only 9 months long, but the fact that we did not see an increase is in some sense very good, because this is different than the increase seen and the increased brain atrophy seen with certain recently reported Huntington knockdown studies. So because we have these interesting and positive results, we plan to proceed with a phase 2-3 large multi-center double-blind placebo-controlled study, hopefully to start later this year. We're finalizing the study design, but because now we have this predictor of response, we believe we will likely enrich the patient population for those individuals who have a high baseline level of intrinsic complement activity.